Hello, today we're going to talk about LP little a. And the question is it ready for prime time? That's actually the title of an article that was printed in JACC about JACC, the Journal of the American College of Cardiology, in September of 2014. It's interesting, about 3 years later, 2.5 years later, it went into prime time, whether it was ready or not. A fellow named Bob Harper, a well-known fitness guru, had a heart attack in his early 50s. Went on to say it was genetic, and then went on to say later that the genetic cause was LP little a. So we'll talk about what LP little a is, go through a review on it, and then talk about what to do about it. So, but first a brief introduction. I'm Ford Brewer, Dr. Brewer with PrevMed, heart attack, stroke, cancer, disability, dementia prevention. Basically helping our patients prevent the ravages of aging through lifestyle interventions and medications where indicated. Now this is the article from JACC. Basically, I don't think the article moved far enough. It did make a couple of good points. It said, look, it was an editorial of a Willett article, an article by an author named Willett in that same edition of JACC. They basically said, look, LPA matters for prevention purposes. As seen in that Willett article, up to 40 patients will have a change in their status regarding risk based on LP little a status. And in most cases, that's going to be somebody who you thought didn't have much risk, but you found out they had a lot more when you start looking at LP little a concentration. He did go on to make the point, and it's true, lipid management standards continue to change, so there is a lot of confusion around what to do for LP little a. So we're going to talk about that. First of all, what is LP little a? LP little a is LDL, but it's a genetic variation of LDL. The biggest part of the genetic variation is the Kringle repeats. That's these things. So if you remember, LDL is what we call the bad cholesterol, and there are a couple of components to it. One is the cholesterol. One is the protein, or the apolipoprotein. In most cases, it's what we call ApoB, but in this case of LP little a, it's a specific different LP little a apolipoprotein. And it's got this hook of Kringle repeating subunits hanging off of it. Remember that, because we'll talk about it in a minute. There's a theory that those repeating subunits in the hook there is what creates the problem. Now, here, let's look at another version of this. This is a visual of it, and here's the modified LP little a, or modified LDL. You remember LDL, like all of the lipoproteins, are basically there. The body makes proteins to keep lipids or fats or oils from forming large balls in our bloodstream. Because a large ball of lipid is the same thing, we call it a fat embolus. It can kill people just like a heart attack or a clot. And actually it does happen. You see it in major trauma when people break major bones and they get a lot of release of fat from their bone marrow into their bloodstream. So that's what LP little a is. It's a genetic variation of the proteins used to keep fat in microscopic particles in the blood. Now, LP little a does a couple of things. Number one, it's what we call thrombogenic. in other words, it collects red cells and clots. It increases clot formation. It also is what we call atherogenic. It increases laying down of plaque. There are some people who would argue that Lp(a) is actually what we call an acute phase reactant or a phase 1 reactant. Basically, that means it's an inflammatory molecule. In other words, it's set up to help us fight off infections and foreign bodies and help us heal. Well, that inflammatory process is not good on a long-term basis. As we know from other discussions and videos, that inflammatory process causes heart attack and stroke. There's actually even a Linus Pauling and a Dr. Rast have been pushing a theory called the unified theory related to vitamin C. They're saying that this Lp(a) is a genetic variation which was developed in order to deal with problems with animals that cannot make their own vitamin C. There are only 3 or 4 animals, humans being one of them, that cannot make our own vitamin C, and therefore our blood vessels, the connective tissue, breaks down. Let's get beyond that theory and start talking about treatment for a minute. Okay, this is from the Lp(a) Foundation website. This is a link to that website. Basically, it's a meta-analysis. In other words, you remember meta-analysis means analysis of all the literature available on a certain specific item. Basically, this is a meta-analysis of niacin and Lp(a). Basically, what they're saying is there's positive effects of niacin alone or in combination with statins and other treatments on all cardiovascular events and on atherosclerosis evolution. In other words, niacin helps. You look at the research, solid research out there, and it helps. Now, there are a couple of other studies which don't support that, and that's where a lot of the debate comes from. One study more recently said niacin may decrease the level of Lp(a), but it doesn't impact cardiovascular events. I tend to lean on this meta-analysis that I just mentioned because there's so many more studies involved in looking at that. Now, let's look at some other treatments for it. Okay, niacin, as we've seen, 30 to 35%. Actually, I've seen 50 and 80%, but on the whole, you'll usually see a 35% decrease in Lp(a). Statins don't decrease Lp(a). So why do docs often give statins for patients that have Lp(a)? That's to decrease the other problems like LDL. The chief of preventive cardiology at Mayo will say, give statins for people with Lp(a), not to decrease the Lp(a), but to decrease the LDL. I end up giving a lot of statins to Lp(a) patients, but as you know, I'm not that often concerned about LDL. I am concerned about inflammation. So we work on and look at the correct statin for inflammation. There are other treatments as well, L-carnitine, which has been the favor has gone back and forth on that. This one I wanted to mention, Lp(a) apheresis. That apheresis is very effective at lowering. You see it cuts it in half or up to 80%. It's a filter. It's like doing dialysis, and that's a big deal. It takes hours every week, and you have to go to a filtration or dialysis or pheresis center. There's a lot of evidence that that clearly works, but again, consider the cost. There are a couple of new drugs that are out there that are getting a lot of attention. The PCSK9s, 20 to 30% decrease, and now some drugs that are being investigated specifically for this have shown, antisense drugs have shown 50 to 80% improvement in Lp(a) values. Just real brief, what on earth is an antisense drug? Basically, if you consider the DNA and RNA, there's a certain pattern for each protein. You take the mirror image pattern, basically, and it blocks the protein synthesis of Lp(a). That's how the antisense drugs work. So, one other thing I wanted to mention. The normal or the usual run-of-the-mill elevated Lp(a) is, and we have, depending on the cut points you use, whether you use 30 or 40, we'll tend to see 25 to 30% of our patients have some significant Lp(a) elevation. But there are far more serious Lp(a) variations out there. This is coming from a Canadian journal. And the Canadian journals are very focused on this because there's a specific consideration for a variation in a French-Canadian gene pool. It's for SNP, or genetic variation, RS1045-5872. Those patients will have 300 or 400 compared to the 80 to 120. They have a very high level of Lp(a), and with that specific SNP, they'll also get aortic stenosis. There's another delineated SNP or variation as well, which doesn't get so much aortic stenosis. A couple of other points about Lp(a), just from a physiology perspective. Thyroid hormone decreases Lp(a). Testosterone and other anabolic steroids can decrease Lp(a) 30 to 70%. Estrogens decrease Lp(a) by about 30%. Pregnancy can double or triple Lp(a) levels. And ACTH, adrenocorticotropic hormone, will give a 30% decrease in Lp(a). So again, a lot of information out there about Lp(a), but still a lot of debates. Let's go back and summarize what's debatable and what's not debatable on Lp(a). First of all, what's debatable? Should we wait for the antisense drugs? Some people are saying, yep, that's our only hope. I don't fall on that side of the debate. I think there are people that need help now, and there are countermeasures that we're seeing now, including niacin, lifestyle issues, and we'll talk a little bit later about that. When do we wait and turn to a PCSK9? Again, if you look at PCSK9s, they have about the same impact of niacin. So if you're going straight to PCSK9 and not niacin, that's where the debate around that comes from. Some people just think, well, let's wait for the new drug. Does lowering Lp(a) improve morbidity and mortality? In other words, the health, decrease heart attacks and strokes. There are a couple of studies that say, no, that doesn't happen. But to me, it's like the meta-analysis I showed earlier. I think the majority of the literature, the science would say, yes, lowering Lp(a) does decrease events. Is apheresis practical? I don't think anybody would argue that apheresis has a huge impact on Lp(a) levels. Again, it's a question of, is it practical to apply to a large population? Having someone come in every week or two, travel an hour or two to the pheresis station, spend a couple of hours there at the pheresis unit. Now here's what's not debatable. No, let's talk about those. Let's get to where everybody either agrees or should be agreeing. Other root causes of cardiovascular inflammation and disease, like insulin resistance, for example, obesity, sedentary lifestyle, aging, those need to be managed. So for example, if you've got a patient with Lp(a), they're hitting their middle age, you need to start looking for insulin resistance, looking at the lifestyle, looking at other things that lead to cardiovascular disease. Here's three things that are not debated. Niacin lowers Lp(a), the PCSK9s lower Lp(a), and the apheresis lowers Lp(a). So, one other thing that's not debated is that statins don't lower Lp(a). I think all of us need to acknowledge that when you add something like aging or insulin resistance to someone who's managed their Lp(a) in their youth, that's when you start to get problems. And again, so I think when you look at the medical community, we will want to make sure that we treat everything else that we know that we can treat. Then you get folks like myself who will say, let's go ahead and use niacin, and let's not just assume that we can't do anything for this. Thank you for your interest.